So at this stage in our practice, year 2, we are familiar with acute myocardial infarction, its presentation, and how to localize infarct by using ECG. But what I want to talk about in this session is two forms or presentations of MI that involve either the posterior wall or the right ventricular wall, because we don't tend to think about these very often. We have no ECG leads that look directly at these areas of the heart, and we often don't really discuss these in clinical practice. But actually, they're quite important presentations that have subtle clinical and diagnostic signs that we can pick up, and in certain cases, we can adjust our treatment to suit. So to begin with, we'll start by talking about posterior AMI. Now, this is an acute myocardial infarction that affects the posterior wall. That's the infrabasilar region, so the bottom and the back of the heart. Now, this is supplied by the posterior descending artery, which is a branch of the right coronary artery. So it's a large area, and it's quite an important area when it comes to myocardial function. Now, we don't really need to revisit MI. We know what an MI is. It's a blocked artery that causes an area of tissue necrosis and damage. But why do we particularly care about posterior wall MI when we already know that inferior or high lateral MI has a significantly high proportion of mortality? Well, actually, posterior infarct has been shown by some studies to accompany 15 to 20% of normal ST elevation MIs. This is because damage to the inferior or the lateral wall often extends into the posterior area of myocardium. Now, if an inferior or a high lateral MI extends into the posterior side of the heart, this implies a very large area of damage. It's not a small area that's been damaged. This has involved the right coronary and its extensions. Now, isolated posterior MI, as in only the posterior wall has been infarcted, has a relatively low incidence. Some studies, you get different figures, between 3 and 11% that have just infarcted this posterior descending artery. Now, importantly with this, there are no particular clinical cues to indicate that a patient is having a posterior MI. Most patients will present exactly the same as other ACS patients. They'll have chest pain, and you need to be particularly sensitive in order to pick this up, because the standard 12-lead ECG does not look directly at the back of the heart. As you know, all of the leads go on the anterior portion of the chest. So how might we identify a posterior MI? Well, let's think about what leads do actually look roughly at the back of the heart, because they look straight through. Well, the main leads that we want to think about here are V1 and V2, the septal leads. Now, both these leads, or V1, V2, V3, look straight at the anterior portion of the chest. But what we might see is reciprocal changes, as in opposite electrical changes, in leads V1, V2, and V3, because they're directed from the anterior precordium towards the internal surface of the posterior myocardium, as in the inside back of the heart. Because this posterior electrical activity is recorded from the anterior side of the heart, the typical pattern of ST elevation and Q waves that you might see in an MI will become inverted. So ST elevation will become ST depression, Q waves will become R waves, and terminal T wave inversion might become an upright T wave. So this is a good way of looking at it. If we have obvious ST depression, in the leads V1, V2, V3, then we can consider these potentially ST elevation in the posterior side of the heart. And you can see the progressive development of pathological R waves and posterior infarction mirrors the development of Q waves in anteroseptal MI. But in order to confirm it, we will need to use extra leads. So we'll need to extend the 12-lead ECG into the posterior wall by using leads V7, V8, and V9. Now, we obviously don't have 3 extra leads in our standard 12-lead ECG set. So where are we going to put these leads? Well, what we can do is we can displace V4, V5, and V6, and we can displace them round to the back of the chest. So this is where we're going to place the leads. Now, to be particularly particular about this, V7 is going to go left posterior axillary line in the same horizontal plane as V6. All of these leads are going to go in the same plane as V6. V8 is right at the tip of the left scapula, and V9 is left paraspinal region, so close to the spine, but also in between the scapula and the spine. So, if we do this, here's an example of an ECG. Now in this ECG, you can see in V1, V2, and V3, there are large segments of ST depression, and this already increases my suspicion of posterior MI in this patient. So I would get a set of posterior leads for this patient. So let's do that. Let's get a set of posterior leads. So if we do a set of posterior leads on this patient and we relabel them, because it's very important to relabel these leads, so it's obvious to the person viewing the ECG that this is a set of posterior leads, you can see that there is marked ST elevation in V7, V8, and V9. It won't always be this marked. This is quite a severe posterior MI, but this is one option, and this is the only way that we can confirm the presence of posterior MI. Now, I'm not going to go mental about the ECG changes here because obviously ECG teaching is next week, so I don't want you to worry hugely about the ECG identification. What we want to think about is the pathogenesis. So we know that the posterior wall has been infarcted because of this extension of the RCA called the posterior descending artery, and that's where the infarct might occur in posterior MI. So how might we manage these patients differently? Well, actually, we can't manage them differently, but what we can think about is that there is a much higher risk of ventricular rupture, aneurysm, and sudden cardiac death because of the large area of infarct. So keep an eye on these patients. If you suspect posterior MI, then we need to be very careful with their management. And some might argue that doing a set of posterior leads might delay your further care, but actually it takes maybe a minute or two extra to do the posterior leads and confirm where the infarct is. This is important information that PCI will want to know when they're thinking about target arteries. So it is very important to do the correct diagnostics on these patients. So that's posterior MI, and I think that makes a fair degree of sense. Now, I've included some references here. I will put them in the description of the video, and they're on Blackboard as well. There's also some slightly more up-to-date literature, which I will link you to in regard to posterior MI. So the next thing we need to think about, we thought about posterior MI, is right ventricular wall MI, and this is the same in that we don't have a lead that particularly looks at the right ventricular wall apart from V1. So what is this? This is an infarct that involves the right ventricular wall particularly. So this right ventricular wall here. So these are infarcts that involve the right ventricular wall. Now, these complicate up to 20 to 50% of patients with inferior MI. Isolated infarction of the right ventricular wall is very, very, very rare. It's something around 1 to 3% of acute AMIs. But right ventricular wall involvement usually complicates inferior MIs as the area of myocardial damage extends beyond the inferior area into the right ventricle. Now, that's, like I say, estimated at something like 20 to 50% of inferior MIs, and we know that inferior myocardial infarction is the most common presentation. So this is actually quite a high incidence. So it's pretty common. 10% of patients with involvement of the right ventricle will be hemodynamically unstable, and that comes from a very large multi-cohort study. So that's pretty good data. Importantly then, as an extension of that, if you have right ventricular involvement, this is going to increase your morbidity and mortality compared with inferior MI. So we need to think about how we're going to identify and manage these patients because this is particularly important. So are they going to present very differently? Well, actually, there is a wide spectrum of disease, but some of these patients will present with the typical inferior MI. They'll have some extension into their RV, but it won't be particularly symptomatic. It won't cause them massive cardiovascular collapse. We can go all the way from that to cardiogenic shock and heart failure. These patients have much higher rates of extreme hypotension, bradycardia, and like I say, their mortality is much higher as well. So why would that be the case? Well, what does the right ventricle do? It's thin-walled, it functions at low pressure, it's perfused throughout the cardiac cycle because it's constantly It's constantly perfused because it's supplied by the right ventricular circulation. It has excellent collateral blood flow, and that's why it isn't that common to be infarcted by itself, because it has good collateral blood flow. But because the right ventricle is involved, there is a much higher chance of hemodynamic derangements, of hypotension, and these patients are very sensitive to diminished preload, i.e. the filling volume of the heart. We need to be very careful, because if there is right ventricular dysfunction, this may cause loss of AV synchrony, and we may see severe arrhythmias in these patients as well. Okay, so that's the patho. Right ventricle, you don't want to infarct it, you really don't. It is potentially going to cause this shocked, looking absolutely terrible MI patient. So let's just quickly recap that. This complicates up to 40% of inferior STEMIs. Patients with right ventricular infarction are very preload sensitive because their RV has really poor contractility, and they may develop severe hypotension in response to nitrates or other preload reducing drugs. Now, the drugs that we carry as paramedics that are preload reducing are nitrates, specifically GTN. So I want to be quite clear about this. These are the patients that may go into cardiac arrest after being given nitrates. And this is why we need to be careful about inferior MIs. I think we've all seen or heard of that symptom constellation, the patient who has an inferior MI that get given some GTN and they collapse in front of you. The vasodilation caused by GTN can cause a complete loss of right ventricular function and end up in cardiac arrest. So what I'm saying to you is use nitrates with caution in right ventricular infarction. Now, there's some really good recent studies, as in sort of 2020 to 2021, that studied large cohorts of patients and kind of made the argument that the benefits of nitrates outweigh the risks in patients who are normotensive with right ventricular infarction. And to me, that makes perfect sense. I think if your patient is normotensive and is symptomatic, then trying a small dose of GTN is perfectly appropriate. But be aware, just be ready for hemodynamic collapse in these patients. The patients that we absolutely cannot give GTN to, as in ones that are hypotensive, this is an area where we need to be extremely careful. We absolutely cannot give these patients nitrates. So if your patient's hypotensive, do not give them GTN. Now, identifying it, again, we're not going to labor this point because we're going to talk about ECG next week, but the first step in spotting it is to think about it in all patients that have an inferior STEMI, yeah? Now, the presence of right ventricular infarction is suggested by ST elevation in V1 being the only lead that looks roughly at the right ventricle. V1 is the only lead that looks right at the right ventricle. And ST elevation in lead 3 being greater than lead 2. That's because lead 3 is more rightward facing than lead 2, so you might see injury current here. But we can't get a unipolar view of the right ventricle unless we, again, start to think about moving ECG leads. So where might we move an ECG lead? Well, the proper diagnostic way to do it would be to do a full right-sided ECG. This is the gold standard for identification of right ventricular infarction. But conversely, with a posterior infarction, I'm actually going to tell you that this is quite labor intensive and it's quite hard to do correctly because we're not familiar with the technique and we're not particularly good at landmarking. We need to be quite honest about that. I have never done a full right-sided ECG. I don't know anybody in paramedicine that has, so I think it's fair to say that if we've not done it before and we've not practiced it, I wouldn't recommend doing it in the pre-hospital environment. What might be a more reasonable approach then is just moving a single unipolar lead. So what about V4? If we move V4 to the right side, this will provide us a single lead that looks directly at the right ventricular wall. Simple, easy, and it will rule in or rule out isolated right ventricular infarction, and it will certainly give us more information when we're evaluating inferior STEMIs. So this is easy peasy. We move V4 right over to the opposite side of the chest. Makes absolute sense, as in mid-clavicular, exactly the same space, and that'll be easy peasy, yeah? Yeah, absolutely. Okay, so if we do a V4R, and that's what we're going to call this lead, V4R for V4 right, It has a sensitivity, multiple studies say a sensitivity of 88% and a diagnostic accuracy of 83% for right ventricular MI. Again, the same as the posterior leads, make sure that you put a note on the ECG saying V4R to make it obvious that this is a right-sided lead as opposed to the left-sided lead, and easy peasy, job done. So here's an example of an ECG. Now, if we take a second to look at this, if we look at the inferior leads, there's an obvious ST elevation MI going on here, yeah? So this is an inferior STEMI. There's ST elevation in leads 2, 3, AVF, and V1, yeah? Now, the bigger ST elevation in lead 3 versus lead 2 and ST changes in V1 suggests right ventricular infarction. Why is that? Because lead 3 is more rightward facing than lead 2, and V1 is that only lead that looks at the right ventricle. So this is a pattern consistent with right ventricular infarction. So a good way of doing it is to do a V4R to confirm. So let's do a V4R. Okay, so let's have a look at the V4R. So this is the same patient with a V4R performed. This ECG is consistent with right ventricular infarction. As you can see, there's clear evidence of ST elevation in V4R. Let's look at another ECG example. So this is a much more subtle inferior MI, but you can see that there is ST elevation in lead 3, greater than in lead 2. There's some reciprocal depression in AVL and V1. Isoelectric ST segment in V1 with ST depression in V2 and V3. So it's a bit more difficult, this one, but we know, let's just do a V4R on this patient. So let's just do the V4R. So this is the V4R. Now we can tell that this lead is definitely not normal, and we can see from this subsequent ECG that the inferior MI is getting worse. But V4R has a complete loss of R wave height, and it does have ST elevation of more than 0.5 millimeters over the R wave. So this is right ventricular infarction. Okay, so we've talked about the diagnostics, we've talked about the pathophysiology of this right ventricular infarction, we've talked about being careful with nitrates. Now, some of these patients experience a sort of systemic hypoxia despite the administration of O2. And this might be because of right to left shunting of blood in the presence of RV failure due to increased RA pressure because of the dysfunction of the right ventricle. So this may cause persistent hypoxia even with O2 administration. So in those who are hypoxic, it's reasonable to try and correct it, but obviously be careful not to over-administer O2, because O2, not to mention encouraging the production of oxygen-free radicals, but it can also cause cardiac vasoconstriction. So we need to be very careful about that. So they do need careful treatment considerations. We want to maintain that preload whilst administering good analgesia and the rest of our MI therapy. So how are we going to optimize or maintain preload in these patients? Well, we can, first of all, try and avoid nitrates. I'm not saying don't give them. If you need to give them, give them. The other option is to give some IV fluid to augment right ventricular preload. Now, we need to be careful here because we want to avoid inducing pulmonary edema. So this would only be for patients that are obviously eligible for fluids. Very careful administration of fluid boluses. GR-Calc does support this, and there are various studies and professional aggregate opinions that will support this as well. If there are no effect on hemodynamics after a small bolus of fluid, then we don't need to give any more, but it's worth trying to support. We don't use the term fluid loading anymore, but just a little bit extra fluid to try and support that preload is definitely worth it. Now, just with all other MIs, evidence indicates that patients that present within 6 hours of onset have a definite survival benefit from thrombolysis or angioplasty. So if we need to thrombolyze these patients, then fair enough, but otherwise we'd prefer to convey them to PCI, and that is right ventricular MI. So what are the take-homes here? Patients with right ventricular MI or posterior MI, we need to be careful about it. We need to suspect it. We need to look for it. In posterior MI, it doesn't cause that many treatment differences, but it's definitely information that we want to pass on, and it may cause patients to become severely unwell because of large infarct size. And the same with right ventricular MI, but be careful about giving nitrates, and be careful, think about giving fluids, but just be careful. Judicious use of small amounts of fluid is absolutely worth it. Okay guys, so that is right ventricular MI and posterior MI. Now, if you have any questions about these, post them on the Padlet wall and we'll discuss them at a bit further length. And next week we can talk about them in class as well. The treatment considerations that I've told you about now, I have linked to the specific sections of GR Calc that address that, and I've linked some articles as well. So if you want to go and have a look at those, highly recommend it. Thanks very much for sticking with me with this video, and let's move on to the next one.